So I'm going to violate one of my first rules before I even begin, and that is, whenever you start to talk to any group about anything, you should, first tell them why what you're going to talk about is so important and so earth-shattering, and why it should be the most important thing that they're going to listen to today, and so on. And I have to say, I'm not going to do that about blood cultures, because to me, there's a big disconnect, probably bigger than any other chapter in this book. There's a big disconnect between what the evidence says we should do, and we probably even all believe what the evidence is. I'll talk about some of those articles, and what we're really going to do. So when you'll look through all these articles, and I'll convince you that blood cultures almost never change management, and pneumonia and Pilo and this and that, and only 6% of them are positive, and even of those, half as many again are false positives, and then you almost never change management even in the ones that are true positives. And then when you go back and work, Thursday, your shift Thursday or next Monday, or whenever you work next, what are you going to do when that febrile pneumonia patient comes in that you're going to admit to the hospital? You're going to send blood cultures, aren't you? And guess what? So am I. What do you mean you have? Why do you have to?
Because our hospital has generated a pathway, and it says
so they get reimbursed.
Because the hospital pathway says if I'm admitting a patient with pneumonia to the hospital, I have to send blood cultures. Well, why does your hospital pathway say that? Medicare. Because they're going to get paid more. It's this whole CMS stuff about keeping track of quality indicators for patients with pneumonia, for example. It's a perfect example. There are a whole list of quality indicators. There's going to be a report card generated for those pneumonia inpatients, right? And on that report card, your care and the care of your emergency department and then the subsequent care of your hospital are going to get graded on a few things. And what are some of the emergency medicine indicators? Antibiotics within 4 hours. Blood cultures before antibiotics. Think you have to measure pulse oximetry. I don't think choice of antibiotics matters. So he points out that on his hospital guideline, it matters what antibiotic you use. That's an internal thing. I think most hospitals now have constructed some sort of pneumonia pathway or pneumonia guidelines or whatever, and it's based on, we want to make sure we get check marks in all these columns when Medicare reviews these charts because we want to be a quality hospital. Now, we can talk until we're all blue in the face about is it really quality or not, and I mean we have to at least acknowledge that a lot of these indicators were put together with little or no evidence. And we could argue case by case, well, I'm not going to do it because, blood cultures haven't been proven to change management, and I think it's a waste of money, and you have to track down false positives and all this. That's all true, but guess what, doctor? You just got an F on your report card. Do it anyway. So the time to change it isn't case by case. I don't think we can do that. We're all little fish. And I hope guidelines like this at the federal level get reviewed and revised, and I'm sure they will. Today, working your shift tomorrow, you have to live by the rules at this point.
I don't know about the pneumonia, but I know for the ACS benchmarks, if you will, that they've actually done studies to show that if the hospital fulfills all these benchmarks, that there is a better outcome, shorter stays. There have been studies.
Right. So he points out the fact that at least in ACS benchmarks, there is evidence to support that if you follow these benchmarks, you have better outcomes. I'm sure that's true. What things do you think are on the benchmarks for ACS or taking care of patients with acute MI?
Aspirin.
Giving them aspirin, giving them a beta blocker before discharge. Those things we know are powerful. And there's a lot of evidence saying that those things reduce mortality. So the trouble is, whenever guidelines like this are constructed, pneumonia, for example, there's a huge mix between. It's not like evil people trying to say, let's put together the most ridiculous set of things possible and make sure nobody can meet any of these criteria. It's smart people trying to use some amount of evidence and some amount of common sense and trying to put together guidelines that make sense. Well, we know when they do that, there's going to be quite a mixture of things that make a lot of sense and have a lot of evidence that they work, and some things in there that don't have much evidence that they work and that make little sense. Well, to me, blood cultures is one of those things. There's a lot of evidence that they don't change management, yet they appear in the guidelines. You know how committees work. This went around a room and people said, oh, I'm sure there was an argument over whether blood culture should be included. And a more persuasive case, well, let's just put them in there. It's our one chance to get them before antibiotics, and some of the admitting doctors are going to want it. Let's just put them in there. There was some amount of compromise. The fact is they're in there. Yes?
Actually, the way they're in there is they're not in there that you must get them. If you get them, you must have documented what it has in school. That is what the documentation says. So your corporation may be auditing from whether you go back to the guideline, because I have done that. It doesn't say you must get them. It says if you get them, it has to be.
A clarification. We have a clarification of a ruling.
I read the fine print. And so I went back and said, when we do our audits, we need to audit what they're actually asking for. Because we weren't doing very well.
So she brings up the point, and I'd love to see the confirmation of this. I bet you're right. It sounds like you've done some investigative work on this, that the small print of the ruling says if you get them, it has to be before blood cultures. So not that you have to get them. Now, so I would wonder if, as a corollary to that, what if I gave antibiotics in the emergency department and then somebody on the floor a day later or whatever decided, yeah, shoot, we should have done blood cultures, I want to get them and send them off now. Then I'm going to get dinged. Okay, that's the problem. Well, let's look at a couple of these articles. And again, I'm not going to belabor the evidence that blood cultures for particularly pneumonia make a difference in management. I think you all buy that already. How many of you already agree with that evidence? Oh, most don't?
Wait, clarify what you...
Did I trick you in the phrasing? Too many double negatives there? How many of you don't agree that blood cultures don't do anything if you don't give them and don't give the patient antibiotics? How many believe the evidence that blood cultures rarely change management in pneumonia? Yeah, so that's... Now, I don't know if I'd go as far as say they never change it, but they rarely change it. So there are a couple of articles in here. If you want to look at them, I'll point out a couple of them. 1 and 2 talk about a 9% and a 6% true positive rate in patients with pneumonia. They also make the point that usually in most series like this, as many true positives as you get false positives, you get contaminants. And that causes a problem as well, because then you chase down those things and you might make wrong changes in antibiotics. If you get up to the next section, 4 through the next couple after that, are about blood cultures for Pilo. And it really makes even less sense in that setting. Because at least for pneumonia, you can say, well, we'd like to get an organism if we could. Now, truth is, we do really well with empiric coverage. And the port trials have certainly shown us it almost doesn't matter what you put them on. You put them on empiric coverage and you generally cover the right bugs and the patients get better. But Pilo makes even less sense because you have the infected fluid. All right? I mean, you have a better thing to culture, the urine. You can get the organism. And in these couple of studies, 4 and 5, it shows you that the urine is almost always positive and it grows the bug, which is almost always E. coli. The blood grows out sometimes, and when it does, it almost always tells you, yep, it agrees with the urine culture. So why are we going to get blood cultures in that Pilo or urosepsis patient? I'm going to do that one too, right? And so are you. So why do you do that? The one that you're admitting to the hospital, not the one you're sending home. Why are you doing it?
We don't want to fight with the admitting doctor. The admitting doctor wants the culture.
Okay, so there's one practical aspect of it is that the admitting doc is may or may not want it, but probably is going to want it. And this is your one chance to do it before antibiotics. So by me deciding not to do it, I'm basically telling the doc who's going to take care of that patient for the next few days in the hospital, I'm basically telling them what they should do, which sometimes might be a good thing. But in a way, I mean, that doc should probably have at least some input into the case that they're going to manage. What's another reason? Again, it's going to come down to money to a degree. Your hospital gets paid more if bacteremia is one of the discharge diagnoses. Now, there's also some kind of interesting thing along these lines, a billing difference between urosepsis and UTI with sepsis, right? So somebody tell me about that. I just learned about this recently myself.
Anything with sepsis pays a lot more. I don't know exactly how much more, but it's a significant difference in billing.
Yeah, I understand that if your diagnosis is UTI with sepsis, that pays your hospital much more than urosepsis,
Which is the same.
which I always thought was the same thing. Silly me.
Not only pays the hospital, it pays the emergency department, and again, to bring up this fee-for-service, basically the ER docs who get fee-for-service get paid more if they give the type of diagnosis.
Right, so he brings a point. It's not just the hospital that makes more. It's the emergency department. It's the professional fee. So in my mind, it's kind of, I hate to talk about the money stuff and, you should put this instead of that and the semantics, but it's sort of like this crazy game that payers play with you. And you should get paid for the work that you did. You shouldn't get paid less just because you wrote a different word for the same thing. Writing urosepsis instead of UTI with sepsis, you got to be kidding me. Yes?
Clinical diagnosis, you don't need blood cultures to make the diagnosis of sepsis, and you don't have the bugaboo of the guidelines that you have for pneumonia for Pilo. So
That's right.
I think that you can still use your clinical judgment, and you're not going to have a big battle. I think this battle is one more for us, for only for your febrile neutropenic or the small population, compromised people. I don't think in Pilo it's as big a bugaboo as it is pneumonia. When you have that gut twisting thing, it's like, they want you to do the blood culture. So this is not a big deal, I don't think, in Pilo.
Yeah, agreed. And just to paraphrase a little bit, the argument is more lost already for pneumonia because we've got the feds out, at least temporarily. And I actually believe it's temporary. Guidelines and requirements like this tend to get revised and changed. And a few years from now, we're probably going to be talking about a different set of guidelines. Now, let me hit some of the articles in this section, though. There are some interesting ones. 6 and 7. 7 is talking about blood cultures rarely change PID. They're almost never positive. 8 is about cellulitis. Only 2% were positive, and 9 of 11 of those were staph and strep, which you already knew.
Question with that, though.
Yes?
Because just magic word staph.
Mm-hmm.
So what you're doing, is there studies to show you have somebody with a cellulitis who's now febrile? Should you be getting blood cultures because whether it's MRSA and the question of whether they're going to be community acquired?
Good. So he brings up the issue of MRSA, and you just had a talk about that. And I think my take on this is this article was written in '99, and I think that logic was right for '99 when community-acquired MRSA wasn't even on the map. It's like we know these are all staph and strep, we know how to treat those, so why even culture it? Now we've done sort of a 180 on that, and some big chunk of these, depending on your hospital, might be a small chunk. At my hospital, when they survey the sensitivities of Staph aureus in the emergency department, 70% of it is MRSA. So if you don't know what it is in your hospital, I bet your micro lab can tell you because they're all required to do these periodic surveillance studies. So it would be good to find out, if you have a low or high rate. I bet a lot of you. How many of you know that you have a really high rate? That the majority of Staph aureus is MRSA. So I think that really changes the logic of whether you culture or not. We've re-entered an era where it makes sense to culture Staph aureus and look for MRSA. Now you can also extend the argument that when it gets so high, it's like just assume it's there. Then you're back out of culture mentality again, and just treat it. Okay, let me move up to number 13. We'll just make a couple of points about if you're doing blood cultures. There are a number of studies that talk about the timing and the number of sets and the volume per set and all that sort of thing that can help us a little bit to navigate these muddy waters. This is number 13 talks about 37,000 sets of blood cultures at the Mayo Clinic. And they came to a few conclusions. One is the more blood in the bottles, the higher the yield. Now that's intuitive, isn't it? And they found that the best bang for the buck was around 30 cc's for a set. So 15 cc's per bottle. Once you got above that, it follows a curve. The yield continues to go up, but the slope is no longer steep like it was. As you might also guess, the more sets that you get, the higher the yield. If you have bacteremia, the more sets that you take, the more likely you are to capture and identify that bug. So this is a place where the percentages that were actually in the article are a little bit different than what's written in the abstract there. So what they actually found for all of their sets, the numbers that are in the abstract were just referring to those patients who had, I think it was 4 or more sets, which was a much smaller subset. So for the whole study, the yield of one set of blood cultures was 80%. So in other words, of all folks who had bacteremia that was eventually found, 80% of those were found on the first set of blood cultures. That's pretty good. 96% were found in 2 sets. So you can see that the curve rapidly flattens out after that. And it took like 4 more sets to capture that last 4%. So I think you'd all agree that the best bang for the buck there was 2 sets. All the positives that were going to become positive were identified by 6 days, but almost 80% of those were positive within 1 day, and 92% within 2 days. So you can conclude from that, the more blood the better, up to probably 15 cc's in a bottle. The more sets the better, but it really flattens out after 2. And most of those positives go in 1 day, and certainly the large majority in 2 days. Okay, now let's move up to, how about, how many of you collect anaerobic bottles? Or do you know if you order blood cultures, they come and get an aerobic bottle and an anaerobic bottle? Is that most of you? Because that's probably unnecessary. And that's probably a change that we could make right now with our labs, is to delete at least the routine use of anaerobic bottles. There might still be some kind of occasion where you have a suspicion of an anaerobic infection and you want to culture it. The article number 15 would make the case that even when you suspect an anaerobic infection, doesn't matter because oftentimes you're right and you've got it covered with your antibiotic anyway. So in 15, they looked at 6,800 sets of blood cultures, aerobic and anaerobic bottles. Only 36 or 2% of them were positive from the anaerobic bottle. And 29 of those 36 were ultimately determined to be contaminants. So there were only 7 positive anaerobic blood cultures out of those 6,800 sets. And in all 7 of those, it didn't change the management because they were all settings where the doc suspected there could be an anaerobic infection at play here, like a diabetic foot ulcer or a aspiration pneumonia or whatever, and they were already on anaerobic coverage. Okay, so now let's move up to the last few issues in this section. This is a short chapter, isn't it? Especially when you start off accepting that, well, we don't need to convince anybody that they rarely change management. We already all believe that. So if you look at 17 through 20, this looks at that issue. We all agree that we're going to have to do some of these blood cultures, particularly in pneumonia right now, and maybe in a lot of other settings. For me, this decision is about minimizing pain. So I'm not going to do 2 sets of 2 bottle cultures, from different sites in these pneumonia patients. For me, I'm going to do 1 set. Only about 6% of them are going to be positive, and I can get 4/5 of those with 1 set. Now, I use the word set. I'm not even going to do a set. I'm going to do 1 bottle, 1 aerobic bottle. This Mayo study would tell you that you're much better off just putting a bigger volume in 1 bottle than you are splitting it into an aerobic and anaerobic bottle. So that makes it a lot less painful all of a sudden. If all I'm going to do is to get my little check mark on my report card and be a good doctor and have my hospital be a good hospital, I can meet that by 1 bottle, aerobic. Now, can I draw that off of an IV? Or does it have to be a separate stick? It'd be even simpler if I could, just in 1 stick, the nurse starts the IV, draws off whatever blood tests you need, and the culture at the same time, shoots that into 1 aerobic bottle. That's pretty painless that way. Now I'm not even doing extra sticks. But would the literature support that? There are a few studies in here that speak to that issue. If you look at let's go up to 18. In 18, it's kind of a small study, but they took 99 kids, drew blood cultures from a new IV start versus a separate stick, and they had a 1% false positive rate either way. So it didn't seem to make any difference. And I think you have to be a little careful in a study like this. You know, they know what they're studying in that, and I'm sure that you know, they prepped the IV site as a blood culture site. You know, they were careful with it. I think I would believe that you would get more false positives drawing it off an IV site if we're not careful with the IV site. You know, if it's just sort of, you know, wave an alcohol swab over the skin, say, oh, here's alcohol, we're cleaning off, and then start the IV, I bet you're going to get more false positives, more contaminants that way. But if you have in mind, I'm going to treat I'm going to draw blood culture at the same time in this and treat the site like you would a blood culture site, I'm sure that's how they got the same low rate. How about 19? Now, and I don't. Yeah, let's skip 9. The 19 doesn't add much. How about 20? You've seen people draw that, once they draw that blood culture, you know, they have it in the syringe, and now you have to stick it into a bottle in some way. You've seen a lot of people that switch needles, right? You change needles, and the thought of that was, well, maybe there's contamination, I guess, on the, you know, from the skin that's on the needle, and you switch now to a new needle, which certainly increase the risk of needle stick. It might even increase the risk of contamination, depending on how careful you are with that. So it might help, and it might actually even harm. It might increase the rate. So it's a reasonable thing to study. In number 20, with 427 patients getting blood cultures, they randomized them to either change the needle before putting it in, before inoculating the bottle, or not change, or just using the same needle that you just drew the blood with. The contamination rates were about the same in each group, 4% either way you did it. So it didn't seem to make any difference. They also, in the same study, compared drawing it from a skin site versus drawing it from an IV, like we saw in study number 18. And again, they had the same contamination rate. So they sort of did 2 studies in one and found that you don't need to change a needle, you don't even need a new stick, as long as again, they were careful with that IV site, intending that it was going to be a blood culture site. So I don't know, I'd be interested in your thoughts on this blood culture issue. What things you do, what things discussions you've had with your lab or your admitting docs at your hospital. Yes?
I'm just thinking that if you have to take it to medical staff, I think, if you want to make an impact. Because of these issues you're talking about, you know, and then present the stuff and say, now what do you think? And then that way you might be able to get them at least down to 1 or a none.
Yes, perfect comment.
Does make it a little more interesting now.
Yes. It makes us want to culture a lot more, particularly skin infections, cellulitis and abscess, where before you would have said.
MRSA, I'm 13 years, I don't think it's ever changed what I've done.
Right. So he, for those of you who couldn't hear in the back, he raised the issue that these are things that you, policy changes you can make in your hospital at the medical staff level. I'm not talking about, you know, I'm working a shift Monday and I'm going to tell the lab, oh no, we're only going to do one, you know, just solving it case by case, doing one bottle of you know, blood culture, forget the anaerobic. You'd spend more time like talking with a lab tech about, but we always do an anaerobic bottle, doctor. When you order blood cultures, you know, change your default. Do this at a hospital policy level. Bring evidence to meetings. We have a problem to solve. We have to have a blood culture on the chart for pneumonia patients. But let's make this process as easy as we can so we can have high compliance. So we all get the good marks on the report cards. I'm sure you can. I'm sure you can get this accomplished at a policy level. Let's just make the default for when somebody orders blood cultures. Make it 1 bottle, aerobic, and make the default in our department. That's going to be drawn off the IV, the same one as the stick that we draw the other labs. So we don't make it a separate stick, and we don't make it 2 sets, and we don't make it 2 bottles per set. And then if the doctor wants something different, fine, you can order something different. But make the default be as simple and as high compliance as we can. Yes.
My experience has generally been that blood cultures get done a lot more when you involve a specialist. So for our institution, you know, a little kid who maybe looks sick and needs to be admitted for pneumonia, it's pretty obvious it's pneumonia on X-ray. You call the pediatrician and say, we're going to admit to you, did you do blood cultures? No, I didn't. Well, can you? Okay, I guess. Hard to refuse when asked for your help to not do you only do this.
Right, so his comment is, usually, as soon as you involve somebody that you're going to admit the patient to the hospital to, that's when a lot more tests get done, in this setting, blood cultures. I think we find that to be the case with most tests that we do. And I've thought a lot about that issue, and I think that a lot of that is a reflection of, your mindset is to, as quickly and efficiently as possible, get to the problem and the disposition. Figure out what's wrong and get to the disposition. Most docs from other specialties, if they're admitting that one patient for one disease, they're not thinking in terms of what are the fewest tests I need to do to take care of this patient. It's like send all the relevant tests. I mean, the model, we probably all worked on internal medicine wards or whatever, where you'd order these kind of, QAM labs, CBC and SMH. It's like you don't even, it's a completely different mindset. You don't even think in terms of, well, do I really need this test and that test? And just order all the relevant tests that I might need. And something might fall out that's useful. And it's a whole different mindset. In the back. So I think if I could hear you right, is what you said that sometimes if you're admitting somebody with Pilo or UTI with sepsis to the hospital, they want a blood culture because if it comes back positive and they had bacteremia, they're going to treat them differently somehow. Yeah. Yeah, this goes back to that, that touches on the issue again of how am I going to tell another doctor how they should take care of a patient in the hospital. I mean, we can certainly have a discussion about what the evidence shows and this and that, but ultimately, I'm going to do my part the way I think is best for the patient. The admitting doctor is going to do the same. So there can certainly be discussion, but I have a hard time telling him what he or she can or can't do. At the same time, on the example you used, UTI with sepsis, we take care of Pilo patients all the time and send them home, send most of them home. Most of them are young, healthy women who get much better with a little bit of treatment in the ED and are safe to go home. We have a huge experience with managing them as outpatients. What happens when you do blood cultures on a lot of those? A lot of phone calls, exactly right. Your buddy working the next day gets to field the phone call from the lab where, oh my God, there's gram-negative rods growing in the blood. So what do you have to do? Now you have to call the patient. You have to do some kind of follow-up. You can't just ignore that. Gram-negative rods growing in the blood? Shoot, you pull the chart. Darn it, the patient was discharged home. I got to track this person down. So you call home, and what do you find out?
It's the wrong phone number.
Well, presuming you can reach somebody, yeah, it's the wrong phone number, there is no phone, yeah. Presuming you can reach somebody. Oh no, she's shopping. I mean, they're all better, right? There's a big disconnect between bacteremia and Pilo, for example. Patients get a ton better. There's only a loose association between which patients fail outpatient management and have to come back to the hospital. When they correlate those who had positive blood cultures and those who about the 10% or so that you see that fail outpatient management, they're different groups. You would think that, well, maybe the ones who had bacteremia were the sicker ones and they're the 10% that are going to fail and come back to the hospital. There's a big disconnect, and there's only a loose association between those. Most of it is for vomiting, and most of those who came back did not have a positive culture. The ones who had a positive blood culture, most of those get better and don't come back. So the argument about it's going to drastically change the length of treatment and what you're going to, as inpatients, they still treat them clinically.
I've always assumed, but I've never seen the literature for endocarditis or suspected endocarditis. I assume cultures, I've always been told, do work, but I've never seen the literature.
Good. Okay, so he brings up the issue of endocarditis. Now we're bashing on the usefulness of blood cultures and so on. There are certainly times that blood cultures are helpful. Endocarditis is the perfect example. And for endocarditis, you'd probably really take to heart the Mayo study in number 13. That's the primary way you make that diagnosis. And they tend to be hardy organisms that are difficult to grow in culture. And that's a setting where it makes sense to get multiple sets of blood cultures. It actually may be reasonable in a patient who's at risk, IV drug abuser with relapsing fevers, to do multiple sets of cultures over time and not give antibiotics in between. That's something you're going to have to work out a plan with if the patient's coming in the hospital with whoever's admitting them, or if they're not, whoever's doing their close follow-up. But that's actually a perfect example where just doing one aerobic culture isn't the right thing to do. Any other comments before we close up there?